Okay, so we have now a session on anti-IgE, Omalizumab. It's my great pleasure to introduce Dr. Kai Michael B. Dr. B is from Germany. He performed basic research studies on lung inflammation at the National Heart and Lung Institute at the Imperial College of London. He is board certified in internal medicine and pulmonary medicine. He founded multiple respiratory research institutes such as INSAF and Aaron Consulting in Wiesbaden. He's the medical director there. He published many articles on pathophysiology, pharmacotherapy of asthma and chronic airway disease, even in the New England Journal of Medicine. He reviews scientific articles for biomedical journals such as the ERS, Chest, and Clinical and Experimental Allergy, and others. He is a member of the ATS, ERS, German Society of Pulmonology, and Association of German Allergists. He is a member of scientific advisory boards of various biopharmaceutical companies. He will be talking today about Omalizumab, a targeted approach to improve uncontrolled severe allergic asthma. Dr. B.
So, thank you very much for your kind introduction, and also thank you very much for the invitation here to come to Lebanon for the first time, actually. I've been here. I haven't seen much of the country yet. I've seen the airport, the hotel, a little bit of the Corniche, but I've seen, obviously, from the plane, it's obviously a beautiful country. You have a lovely coast, and you have the perfect climate. So I've been waiting for this type of weather now since last October. So in Germany, we are now desperate to see a bit of sun and have a bit of a nice climate. So it's very nice to be here. I appreciate that you are a multilingual country, so I do my best. I would like to say Meseo Khair, Keifa Haluk, bonjour mesdames et messieurs, and of course welcome everybody to this talk. It's my great honor and my great pleasure to give you a talk on the role of Omalizumab in treatment options for particularly severe allergic asthma. And of course, I will give you a wrap-up of evidence for this drug in this particular indication, but I'd also like in my talk to point maybe in some future directions, not what is exactly now in the label or in the approval for the drug, but where the direction could actually go, before discussing the optimal or the individual optimal patient that would fit into a treatment with Omalizumab with you and the audience here. So, treatment of asthma, actually, even severe asthma, could be easy if you go to the internet, because in the internet you find something like that. So I haven't actually looked at that book, but obviously it seems to be a very concise book on how to cure your asthma in just 1 week. Now, if that was a very successful approach to asthma treatment, probably I wouldn't be here, because all the patients actually with asthma would have cured their asthma within just 1 week. So obviously, it's not based on science, this book, anyway. So it's not, unfortunately, it's not that easy. We cannot cure asthma, and particularly we cannot cure asthma in 1 week. We have many patients that we can control with asthma, or we can make them lead a normal life, or a life that is basically only affected by minimum symptoms. However, unfortunately, there is a population of patients with asthma that are not controlled and that are not happy, even with appropriate medication. And something I'd like to stress very much, and I'm quite sure you all know this slide, about the GOAL study, because very often if you open up public media and these surveys where they say, well, in our country we fail to achieve asthma control because many of our patients are not controlled, and basically very often the bottom line is a little bit of an accusation. Thank you. It's better like that. The bottom line very often has a tone of accusation a bit. It says in the end, well, basically, we physicians, we are all idiots. We don't manage to achieve asthma control in all the patients. Well, we have to face the simple fact that even if we use appropriate treatments, it is not possible to achieve asthma control in a certain population of patients. So it's not your failure, it is just the fact that obviously there are some patients that even on adequate treatment, they are not totally responsive and they are not controlled. And this it has been addressed, for example, by the GOLD study, where patients were put on different levels of pre-treatment. They were put on appropriate treatment with ICS and LABA, and it was just a simple evaluation of how many of these patients actually would remain uncontrolled. And it's now been replicated in many studies that whatever means you use, you have a population of 30 to 35 or sometimes 40% of asthmatics that even with adequate doses of inhaled corticosteroids and long-acting beta agonists are not well controlled in their asthma. And this, as I said, has also been replicated in the INSPIRE study. As you can see here, there is here a differentiation according to several levels of control measured with the ACQ, the Asthma Control Questionnaire, which is a nice and validated instrument. It's very often used in clinical trials, and we know that, well, everything in this score that goes to 0.75 is something that is well controlled. If it's higher than that, it's not perfectly controlled, and if you have a score on average of larger than 1.5, you're uncontrolled. And you can see that in these patients, even despite high dose or ICS and LABA, 50% of patients were not controlled. So really, even if we do adequate treatment, patients are not fully controlled. And of course, asthma control has impact on quality of life of these patients. It's also something that, I mean, when I grew up and I went to medical school, the concept of quality of life and asthma was not very well established. But nowadays, even health technology assessment bodies very much focus not only on physiological outcomes, but really want to see what is relevant to the patient, what are patient-reported outcomes. And of course, quality of life is something that can be measured in asthma. It's not something that you can do in your everyday practice because the questionnaire is rather cumbersome. However, it's a validated instrument, so in controlled clinical trials, to get evidence about the effect of drugs, we can measure quality of life in asthma. And we can clearly see that the poorer the asthma control is actually, then the overall quality of life is diminished in patients with asthma. I mean, that's not very surprising, in fact. And of course, it is also that the burden of asthma is higher for those who are uncontrolled than if you are controlled asthma. Again, I mean, there seems to be some logic behind it, but nevertheless, this needs to be demonstrated. And it's clear that in terms of work days or school days lost for children, physician visit, hospital visits, or emergency department visit, it's clear that those patients who have uncontrolled asthma always have the higher burden of disease than those who are controlled. Something that is in a way self-evident, but needs to be shown in controlled investigations. Now, asthma control is not all about single or one best parameter. It's, in fact, if you like, it's a composite measure of different dimensions in asthma. Some of them are objective, some of them are subjective. So it's very important to basically take all the aspects into account. It's not about lung function measurement, because you know probably in your practice better than I do that there is, on individual basis, sometimes a major disparity between lung function and asthma severity. We have this brittle asthmatics with normal lung function in between who have terrible exacerbations only 24 or maybe 40 hours later after you've seen them. And you may have patients that have 50 or 55% FEV1 predicted that never have an exacerbation or are totally stable over a long period of time. So there's disparity between objective measurements and asthma control. So it's a composite measurement. It takes into account symptoms, of course, nighttime awakenings, the use of medication, particularly, of course, how many puffs of a rescue beta agonist does the patient require, steroid bursts, quality of life, and, of course, what is very important and what drives the severity of the disease is the number and the frequency and severity of exacerbation. I think there's no doubt about that. And this whole concept of asthma control, with all these questionnaires we're using, it is clear that also if you ask patients what are you most afraid from, is having an exacerbation, having an acute attack, maybe being forced to use systemic steroids or even being forced to go to the hospital. That's really what is worrisome for patients in an acute setting. And of course we can support this by some some objective measurements like, of course, lung function, hyperresponsiveness. We have now some measures of inflammation. And if patient do that. Some patients do. I have an example for that. You can measure peak flow variability. And for that, we have some items to assess asthma control. Some of them are easy, some of them are less easy to use. The questionnaires that I usually use in clinical trials is the asthma control questionnaire. It's validated and it's also responsive to intervention. And also the asthma control test is something that's probably very popular. These are relatively easy to use, even in clinical practice. Whether you use the 5 items or the 7 items in ACQ with or without lung function, I leave it up to you, but I think it's a nice instrument. However, the asthma control questionnaire lacks a bit on information about really severe exacerbation and hospitalization. It's not covered there. So this is one of the reasons why this severity of asthma instrument is now being developed. Severity of asthma, trying to identify those patients who are really at high risk, maybe being of better discriminative value than ACQ or ACT. In particular, try to identify those patients who may be good candidates or appropriate candidates for treatment with a drug like Omalizumab. And this is a bit more specific, and again, you will find the same in evaluations of symptoms and stuff like that. However, you also find here information about prior hospitalization and prior intubation, and you get a lot of points and a lot of score, as you can see, for prior hospitalization or prior intubation, because that is obviously a very reliable predictor of future risk for asthma in this tool, and obviously it seems to work and is currently in the process of being validated. Now, if we talk to severe asthma, very often the question comes up, well, if you have severe asthma, maybe the damage is all done, and what is the precise role of allergy in asthma? It is difficult to define in individual patients the truly causative nature of selected allergens unless the patient really reports a typical symptom according to exposure. But however, in severe asthma, these patients have symptoms more or less all the time. So it's merely rather an association in many patients rather than really pointing in a direct causal relation to a certain allergen. However, the prevalence of allergen in severe asthma is nevertheless high. In my country, we have a tradition of dealing with an entity that we call intrinsic or non-atopic asthma. And if I talk to pulmonologists there, many of them will, as if in a reflex, will say, oh, severe asthma, that's usually non-atopic. But that's not true. The role of allergy or the prevalence of allergy is not as high as it is, for example, in childhood asthma, where we have 90% positive skin tests in children. However, even if we look at adults or adult onset severe asthma, we will find that the majority, more than 50%, 60-65% of asthmatics do have a background of relevant allergens. This has also been replicated in the UK Severe Asthma Registry in different areas around the UK. And you can see here the positivity for patients tested in the skin test. And you can see that there is variability in regions. However, it is, with the exception from Belfast, for whatever reason, you will find that more than 70 up to 97% of patients with severe asthma in the UK have at least one relevant sensitization. And this is very confined to seasonal allergen. In some regions, you really have 90-95% positivity in skin tests to certain perennial environmental allergens. So there clearly is a role for allergic sensitization in adult severe asthma. And we know that in children, for example, there's also a correlation on average with the level of IgE, the total level of IgE, and the severity of asthma. So there's very good rationale actually to target IgE in the treatment of severe asthma. Now this is where we're coming from. Prior to Omalizumab, to be honest, we didn't have any evidence for any add-on treatment beyond high-dose ICS and LABA, maybe theophylline. But the evidence for theophylline has already been very weak. We did use leukotrienes, being aware that, in fact, in those very severe patients, we don't really have evidence on that. And this changed dramatically with Xolair. So at that time point, we tried to put these patients on whatever treatment that we believed could be helpful. And for the majority of patients, that meant we would put them on oral or systemic corticosteroids. However, many patients with severe asthma were so afraid to use oral steroids that doctors would rather take some very strange or exotic drugs like methotrexate, cyclosporin, or whatever immunosuppressants, put patients on to spare them the oral corticosteroids. So you might argue, well, this is a bit of actually, having the choice between the devil and Beelzebub, in fact, so it's not really very appropriate to spare someone the oral corticosteroid and put him on cyclosporin. However, this was a situation we didn't have evidence for add-on in severe asthma for any potential add-on treatment, so we ended up with oral corticosteroids. And that changed, of course, with the upcoming of Omalizumab, anti-IgE treatment, which is now part of the step-up in the guidelines, where there is clear evidence now and clear recommendation that in suitable patients that are not controlled on medium high dose ICS and LABA, there is a clear recommendation for an option in these patients to use anti-IgE. So it's really a success story. And you have to really see, now I'm doing clinical research now for nearly 20 years. And I've done more than 100 clinical trials, and many of them in severe asthma. And over the years, now this is actually what evolved out of my experience in clinical trials. Every one of these protocols and all these trials start with a message that, well, this and that mediator is a key player in the pathogenesis of asthma. So it's of pivotal importance that we treat this key mediator with our experimental drug. However, if you look at all of these soup of mediators and cytokines and stuff like that, the question is what has come out of that, all of this concept. In fact, the only drug that emerged, and that was shown now on a very high level of evidence to be clinically effective, is of course anti-IgE. But we also learned from the development of anti-IgE that the future of asthma treatment, well, we can say it's the presence of asthma treatment, but it's going to be probably also the future of asthma treatment. And companies, particular pharmaceutical companies, had to learn this, that it is not all about having a blockbuster. It's not necessarily you need a drug that targets all patients with asthma to really get the largest piece of the cake, only to create blockbusters. We now know from other indications, but now with Omalizumab, that it is also very important to do something which we will call nowadays personalized therapy, or adopting or bringing the correct treatment to the patient, and that of course generates something which we now call niche busters. However, pharmaceutical companies now already have learned that sometimes niche busters are much more easier to develop if you have a clear target than a blockbuster nowadays. And this is why some of the reasons we are now getting back into that, we're having a lot of research activity, and maybe we have some other drugs in particular phenotypes and indications in asthma. Now, this is Xolair. Omalizumab, as I said, actually is the only drug that emerged out of this, biotech run in the 90s, the only drug that was now approved for the treatment of severe asthma. This is the EU indication, severe persistent allergic asthma. You need to have positive response to skin test or in vitro reactivity to aeroallergen. You must have patients that are symptomatic, and they must have a history of exacerbation. And in my country, we have also the restriction that at least in those patients who are adults or adolescents, we need to document lung function less than 80% predicted. I don't like this criterion very much. Asthma is a variable disease, it's not COPD. So this is probably the weakest part. However, since in many of the pivotal trials, the entry criteria were limited to asthma patients below 80%, well, regulators adopt this and say, well, you only demonstrate efficacy in those patients, so this goes into the label. I don't see any scientific or medical sense behind that. We're dealing with asthma. However, we have to deal with that. Now, Omalizumab has a variety of clinical effects in asthma, particularly in severe asthma. Most of all, it's an anti-inflammatory drug. It's very important to know. It's not a bronchodilator. But given this anti-inflammatory efficacy, there's a lot of clinical effects that we can demonstrate with Omalizumab, and it impacts on all these important outcome parameters in asthma, particularly in severe asthma. And you know better than I do that, of course, Omalizumab is not dosed on a fixed dose, because the dose has to be adopted according to body weight and total IgE. So before you put a patient on treatment, you have to put him on a scale to measure his weight. And the other thing is you have to measure total IgE, and then you calculate the dose. That was the old label. We now have in the EU, we have the dose extension, so we can go to a higher level of IgE in comparison to body weight. So that's it. So if you say very often you get the cost argument. You can say to the patient, well, lose weight, maybe you lose 20 kilos, and then the drug, the treatment gets cheaper. It's usually not. It may be helpful in obese patients anyway, so that may also improve their asthma. But you have to calculate it according to weight and to total IgE. If you use Xolair in patients with asthma, you see, as I said, you see effects on airway inflammation. This is a biopsy study that's been done where they actually measured ECP staining and tissue IgE pre and post treatment with Xolair, and this really is a proof of concept demonstration. Yes, in fact, it reduced eosinophilic inflammation and it reduced tissue IgE after treatment. So that was proof of concept for the anti-inflammatory mode of action that it has directly in the target compartment. Now, because of the anti-inflammatory mode of action, it was clear that the clinical studies in this population should be designed to target exacerbation as a primary outcome, because that's very important, and that is very likely to show a response with an anti-inflammatory drug. And this has been studied now in a large variety of studies, and all of them looked at asthma exacerbation. And I'll just show you as an example, because I was one of the co-authors of this study, was the Innovate study. This is a representative example of the study population that was in these trials. It was very severe asthma. Most of them had low lung function despite high-dose ICS and LABA, and many of them had other controller treatments, leukotrienes, theophylline, many of them also oral steroids, and they, of course, had to have a documented history of exacerbation during the time period prior to entry into the trial. So there's no doubt, I'm not going to detail here, but just to illustrate, there's no doubt that in these studies, the most severe patients with asthma really were represented. I can tell, in this study, I had 6 patients on my own, and I can tell you, in fact, these were those patients that really gave me the worst nightmares in my everyday clinical routine. So really severe patients. Now, this was the primary endpoint, significant reduction in asthma exacerbation rate in treatment over half a year under Xolair versus placebo. So, of course, that was not placebo treatment. It was add-on Xolair or add-on placebo. So all these patients on placebo, of course, had maximum asthma therapy. So that was for the first time really for a new drug in this particular population, evidence-based, a clear reduction and significant and relevant reduction in exacerbation in this population. And that also led to a reduction in the emergency visit rate that were associated with severe exacerbation. So a very nice picture, consistent picture. Reduction in exacerbation, severe exacerbation, and also as a consequence of that, a reduction in emergency visits with Xolair. Now, this has also recently been replicated. The United States consider themselves to be totally different from the rest of the world, so they did an extra US-based, because Innovate was the European approval or registration trial, so they did something, they did an additional phase 3 trial, because in their country they had a lot of studies that were not exclusively done in high-dose ICS plus LABA, so they did a different study only in the US, looking at patients, high-dose ICS LABA, basically it's the Innovate population. And unsurprisingly, they replicated the result, which is very fine, and it's very reassuring. They also were able to show in this very severe population, US-based population, that they showed a 25% reduction in the exacerbation rate. So taking that all together, if you put all the studies together and you do a pooled analysis, that means on active treatment versus control treatment, you had on average a reduction in 38% in the exacerbation rate. That is really a dramatic response in this population where we didn't have any evidence for any add-on treatment prior to Omalizumab. Very nice result, very reassuring. And this is the pooled data for all the other outcomes, emergency visit, hospital admissions. Same story, a significant reduction in hospital admissions, emergency or whatever that is. So really reassuring that it does something on these severe exacerbation. And in the study that is called the EXALT study, a different study, they also counted the days that patients spent in hospital when they were admitted to hospital because of asthma exacerbation. And in fact, you could also reduce the length of the stay in hospital with Xolair versus the treatment optimized asthma therapy approach without Omalizumab. Now, has this got something to do with asthma control? Of course it has. You can measure asthma control in these patients, and of course, not very surprisingly, you get a difference in, this is the extra study, US study again, you get a difference, significant difference in the change in asthma control on omalizumab versus control group. So this impacts not only on exacerbation, but obviously also on asthma control. And ultimately, again, this is a pooled analysis of a publication we did a few years ago, taking together all the quality of life data for Xolair. You see a very nice and very consistent improvement in the asthma-related quality of life. So that, again, gives you the whole picture, reducing exacerbation, improving asthma control, and ultimately impacting on patients' well-being in terms of quality of life with omalizumab in comparison to control. Now, a very interesting aspect has been studied in the United States in a different study, an inner-city asthma study. Inner-city asthma in the United States is very much dominated by patients having house dust mite and cockroach allergen. Cockroach usually, for whatever reason, it's called the German cockroach. I don't know whether this comes from Germany, but the Latin name is Blatella germanica. I find this quite insulting, actually, because we have a lot of cockroaches in Germany, but however, it's the German cockroach they are allergic to in the United States, however. So this is typical for inner city asthma there. So they did a study to improve inner city asthma in adolescents and adults that were sensitized to dust mites or German cockroaches. And very interesting, they replicated everything that you've seen before, exacerbation, symptom, and all that stuff. But what was very interesting here was there was not only a reduction in the exacerbation rate, but also, if you look at the seasonal variation in the exacerbation rate, you can see that there clearly were two peaks in the placebo group, seasonal peaks here in spring and in autumn for the exacerbation rate, and omalizumab actually flattened or prevented these peaks of exacerbation. And funny enough, the peak of exacerbation does not necessarily have got something to do with allergy exposure, because most of these exacerbations in the placebo group were triggered by viral infections. And there's some mechanistic evidence to show that, for example, if you have allergen exposure, particularly with German cockroach and house dust mites, because of the proteases in these allergens, that causes damage to your epithelium. And that makes you more prone to viral infections on your epithelial level. And the reason why this flare-up of viral exacerbation is prevented is that if you actively prevent allergen-induced damage to your epithelium, the likelihood that you acquire viral infection obviously seems to be lower. I find this a very fascinating result. It's not proven that this is the mechanism, but it's a very, very interesting thing to think about, and there's not a lot of research going on to study the interaction between allergen-induced damage to epithelium and barriers, mucosal barriers, and viral infections. Now, what about, let's have a shorter look at those patients. We have other add-on options. We know that we can add leukotriene antagonists. Does it make any difference if a patient is not only on high-dose ICS and LABA, but also whether he already is on high-dose ICS and LABA plus a second controller? And again, the message remains the same. Even if you look at those patients who are treated with Xolair on top of leukotriene antagonist and ICS and LABA, you get the same results. You get you get a reduction in the exacerbation rate, and you get a reduction in the need for oral steroid bursts, irrespective of patients being on anti-leukotrienes or not. We always say anti-leukotrienes. The funny thing is, in Germany we only have one, so it's only Montelukast. There are regions in the world where you have different drugs. Probably in Japan you have 20 of them, but in my country there's only one. But nevertheless, we keep saying patients on anti-leukotrienes. Very funny. You have more in Lebanon? No, you only have Montelukast. Yeah. Okay. So this was very much controlled evidence from clinical trials, and it's also very important, it's real-life data. In the end, you have to take the treatment based on evidence. You go out and treat your patients. What do you see in your patient? Now, this is very interesting data from France, where they did a real-life study. It's just been published. Actually, it's only been published EPUB. So the ink on this paper actually hasn't even dried. It's very, very fresh data. They followed up patients over 1 year on omalizumab without a control group, just to follow them. And they compared asthma control at study entry and after 1 year of treatment. And you can very nicely see how gradually the proportion of patients with poor asthma control decreases, and those who have good asthma control dramatically increases after 1 year. And this is associated with a dramatic real-life reduction in the experience of exacerbation patients had over 1 year. So at baseline, historically, this was the number of exacerbations the past year, and this is prospectively collected, the number of exacerbations in the treatment year under Xolair. So really, I mean, although this is observational data, it's uncontrolled, but nevertheless, we usually want to see real-life data, and this is real-life data. It's not the same as controlled clinical trials. However, I find this also very reassuring and very interesting. And in the UK, they have also studied a few patients whether they could discontinue or reduce oral steroids, also a real-life study over 1 year. And you can see that there was the majority of patients were either discontinued or markedly reduced or stopped in their OCS dose. Something happened with the formatting here. I don't know what it is. I have no idea. So that should be reduced, this should be stopped, and this should be continued. Very strange things happen in between PowerPoint versions of different computers. I checked it 5 minutes ago. It was okay. So the funny thing about science and technology is, even if you are a very, very scientific person and you believe in rationalism, with these computers you become a believer again. Because definitely in these computers things happen between heaven and earth that cannot be explained by science. And one of these is the reasons why all these formatting issues sometimes happens. So it's really funny. I don't know why this happens. Anyway. Now, there is now some evidence from large-scale clinical data that in the group of patients that are appropriate for treatment with omalizumab, whether in this group there may be patients that have extraordinarily good response in comparison to others. So in this extra trial in the United States, they also analyzed some biomarkers. And it's also a very new publication, just been EPUB'd a few weeks ago. And they looked at some classical biomarkers of Th2-driven inflammation. They looked at exhaled nitric oxide, eosinophils, and they measured periostin, which is very fashionable at the moment. Everybody's doing periostin. Probably nobody knows what it tells you, but it's very fashionable. If you want to apply for a grant, just add periostin in the title. You probably get tens and 20s of millions if you have periostin. Very fashionable. Now they looked at those patients, they just simply dichotomized their patients, saying high level or low level. And they said, look at ENO, EOS, and periostin. And in fact, in this extra study, although all patients on average improved with omalizumab, those patients who were in the higher median group of high nitric oxide, eosinophils, or periostin had a more pronounced effect versus placebo in their reduction of the exacerbation rate. So it's a bit of a conclusion that maybe even within this group of patients that is appropriate for treatment with Xolair, there may be a particular, if you like, responder or fantastic responder group. But however, this needs to be validated in different population and also in different trials. But it's a good idea. Very often the question comes up, how long should I treat my patients? Well, in principle, it's a lifelong therapeutic approach. That's the answer to that question. If you discontinue anti-IgE, the IgE comes back and eventual symptoms come back. However, you can say pragmatically and evidence-based, you need at least 4 months of treatment to evaluate a treatment response. I mean, that's in a way also logical because although omalizumab has a large impact on symptoms, the main outcome is exacerbation. So you need a bit of time to really see whether a patient that has been unstable now is more or less stable with the treatment. So you really need some time. So you should treat for 4 months at least. And as I said, this is also supported by many clinical data. Now I've heard that in your country you have a particular approach to that. You get it approved for 6 months and then you have to discontinue the treatment. Is that correct? Or I've heard something like that. Which is not a very good idea, actually, because if you could discontinue the treatment, well, it just what happens, the whole story starts to begin again. It's not, if you like, on long term, it's not a disease modifying. It doesn't cure your allergy. It's a disease that is targeting the underlying mechanisms of your asthma. If you take it away, then the asthma comes back. I mean, would these guys also approve ICS LABA treatment for 12 weeks and then say if it's fine and the patient has no symptoms, then take it away. That's a very strange approach. I'm not sure whether this is appropriate. Of course, it's got to do with cost. I appreciate that. But there's not a big science behind that. This looks very complicated, but actually it's very easy. It illustrates you the cause of free IgE in the blood of a patient. So that was not covered with omalizumab. And symptoms, or rescue medication, or whatever, peak flow. Now it's very easy. If you start on treatment, IgE falls, free IgE, and your symptoms get reduced. If you stop the treatment, then free IgE goes up again, and your symptoms come up again. It's very easy as that. You take off the treatment, you wait maybe a few weeks, and after that, you get your levels of IgE back, and then you start to evolve symptoms again. However, so that's not really a good approach to take away the drug after 6 months. You should at least give it, I would say, as I said, it's a lifelong. If you say, well, asthma step up and step down, then I would say, okay, maybe after a year or maybe after 2 years, we know that the treatment is safe. You can maybe try to actually give it a try, taking the patient away, look what's happened. But it's not a good approach. Now, a bit into the future, we appreciate and we know that many of our patients with asthma also have problems with their noses. And apart from this very nice construction, we don't have very effective treatments, in fact, to target both upper and lower airway disease with the same treatment. And I'd like to point out something that has just also been published a few days ago, a very interesting study, studying the effect in patients with comorbid asthma, severe asthma, and nasal polyps. And the funny thing about that is that these patients were recruited regardless of their atopy status. So some of these patients were atopic, some of them were not. And you may ask, why did they do this? Now, they had the group that did this have a lot of experiences with nasal polyps, and they do a lot of biopsy. And they were able to show that in nasal polyps, you have, even if you are a so-called non-atopic patient, there is massive local IgE production in these polyps. So definitely there's a contribution of IgE. And they did this kind of proof of mechanism study. It's not within the label. It's definitely not what is recommended, but it just maybe indicates you that the story of anti-IgE is not told now. There's a lot of potential even in the future. Because when they put patients on treatment with anti-IgE, regardless of their allergy status, they had a dramatic improvement in their nasal polyp score, despite many of these patients having recurrent polyps and having surgery and stuff like that. And that was accompanied by major improvements in the asthma quality of life score. So even if this is not the typical patient in the leaflet, this is very interesting. And obviously in our body, in our organ system, in the target organ, be it the bronchial mucosa or the nasal mucosa, there seems to something to be going on that is not necessarily... That's great, actually. Nice tune. You should do studies on that. I mean, you should correlate something that the tune somebody uses on his iPhone, whether you can correlate that to certain character traits. It's probably very interesting. You hear the strangest, if you go on the train or something, you hear the strangest sounds coming out of these machines. And people sometimes really, I mean, you have maybe elderly people, 75, and then they end up with whatever Eminem or rapper, gangster rapper sound, and you just say, oh, come on, it's not you. Probably the daughter installed it, or their grandchildren installed that for them. Anyway, dramatic improvements in nasal polyps and also in the asthma quality of life. So I think that's a very interesting thing to study. Now, there usually if it comes to safety of omalizumab, there usually come two questions. What about the risk of anaphylaxis? And the other one was in the very early beginnings, there was a discussion about malignancy. So I'd like to update you on risk of malignancy and anaphylaxis. So it's a very short story, actually. We now know that we have several thousands of patients, and anaphylaxis is something that is very, very rarely. It's less than, as you can see here, 0.1% in clinical trials. And in children, it's never been observed. And we are not sure in all of these very few, I mean, you can count them, in fact, cases whether this is really related to omalizumab. However, it's a protein, omalizumab, so in theory it can happen. And in those patients who had some kind of rash, or if you like, anaphylactic fragment, it happened sometimes after the first dose. However, it can also happen on continuous treatment. So this is why we monitor patients after the injection for maybe 30 or 35, 40 minutes. I mean, this is what you do with immunotherapy also. And if you compare the incidence of anaphylaxis with solayered immunotherapy, there's a dramatic difference in favor, actually, of omalizumab. But of course, you need to be aware that this may happen. However, it happens on very, very rare occasions. I've seen a rush, it was a rush rather than anaphylaxis, in one patient on first dose, and we decided to put her on the second dose, and it actually never occurred again. And this is the update on malignancy. Now, this is where we started in 2003 because there were some cases in the clinical study program. There was not a lot of confidence. There were only few cases. This is why there was an increased rate with very wide confidence intervals, and this is, of course, why the FDA and other bodies said you need observational studies, large-scale studies, where we follow this up, and you can see the more time evolves, the closer the confidence intervals get, and you can clearly see now that there is not even an increased rate of events with omalizumab, but there's clearly, obviously, now there's a decrease in events with a very narrow confidence interval. This is the AQLO safety study. We will have full publication probably in the first half of 2013. So I think this study, this issue on malignancy is basically, never been an issue, but it's basically told now. So you can forget about the issue of malignancy. So that would be my concluding remarks before I finally maybe show you one or two cases of patients that I identified as those being the best subjects for anti-IgE. It's clear that in severe asthma we have major contribution to cost, mortality, and morbidity, and it's also clear that we have very limited treatment options beyond LABA and ICS, and there's very little evidence to support, for example, leukotrienes, theophylline, and even oral corticosteroids. Probably if you took oral corticosteroids to the FDA in 2013, I can guarantee you the FDA will not approve them. It will say this, we have severe safety issues, you must take this drug away from the market. So anyway, omalizumab really fits in this population because in this target population we can clearly see impact on all important asthma-related outcomes, and that goes along with a nice tolerability profile of the drug. So it really is something that improved the management of these particular problematic severe asthma patients. Now, when it comes to practical management, really, and this is where I like to conclude, is really to try to identify the correct patient for the treatment. And what I hear in many conversations is that sometimes there is a bit of insecurity whether this is an optimal patient or not. But you're not alone with that. I mean, what I tell you, this is academia and science and evidence. What you do is practical medicine. So don't be hesitant because you're not fully aware maybe of all of these studies anyway. I can tell you you're not alone with that. I was a consultant in Germany for applications for Xolair treatment when the drug was actually in the pre-license phase. So when doctors had a patient, they wrote an application and then they approached me and said, am I doing the right thing or is there maybe something lacking? And I can tell you that in these applications, and not all of them were idiots, only 14% of the applications were totally within the label. You can see that a lot of them actually thought this could be nice for a patient with seasonal allergy, or it was at least perennial allergy was not documented. They did not specify the concomitant asthma therapy. They did not actually have evidence of or documentation of exacerbation. Sometimes the primary indication was something different than asthma, anaphylaxis, food allergy, or whatever. IgE very often was above the upper limit. At that time, we had the 700 as the age limit. And the IgE limit at that time, we also had the age limit of 12 years. There were many applications for children. And of course, because we have the spirometry criteria, many of them lacked spirometry data. However, if you take all together and you're aware what is basically these few factors that are in the label, you can find very suitable patients like this patient I'd like to present to you, which is what I think the ideal candidate for treatment with omalizumab. She's she was a 30-year-old female, asthma since childhood. She had all the complex atopic diseases, allergic rhinitis, atopic dermatitis, multiple, as you can see here, multiple allergic sensitizations, pollen, mites, and whatever you like. The problem was she had a cat in her household. And of course, until 2001, where she had a severe exacerbation because of cat exposure, she gave the cat away. She was reasonable. I said, you must get rid of the cat. She did it. However, you know that if you remove a cat from a household, it can take, whatever, years, sometimes decades. Sometimes you never get your house free of cat allergens. So she continued to be exposed, despite she followed my recommendation and gave the cat away. Now, this is the actual treatment that she had. A lot of drugs, high-dose ICS LABA. Despite that, she used phenoterol up to 10 puffs per day. She had montelukast. We even tried an oral long-acting beta agonist because she had nighttime symptoms. Despite all that, we couldn't use theophylline because she had severe heartburn from that. And in the 6 months before we started her on Xolair, she had 6 exacerbations, each with a steroid burst. She was really concerned and she was not doing well. And we thought, well, because of all this allergic sensitization, you may be a very good candidate. She had high total IgE, 560, but as she weighed 60 kilo, that was within the dosing scheme, so we put her on 300 milligram of Xolair subcutaneous bi-weekly. And what really sometimes very funny is what patients then tell you, not necessarily it's got something to do with asthma control, maybe other things. And she noticed 4 weeks after the first injection, when she picked up her daughter from the stable, her daughter was a horse rider, and she never could pick her up because she had severe horse allergy. She avoided that. But at that time, her husband was not available, so she had to pick her daughter up. She was very concerned going to the stable because usually she experienced severe asthma attack and severe allergic symptoms. Now, she could pick up the daughter, actually, without getting symptoms. Now, she waited and waited for symptoms to evolve, but it didn't happen. So that was the first time she noticed, doctor, obviously something is going on. You did something to me that changed my situation. And in the following year, despite she continues and still continues to have severe asthma with a lot of background treatment, nevertheless, in the continuous year, she didn't have a single exacerbation requiring oral corticosteroids. So a very nice result. As I said, we didn't cure her asthma. She still has severe asthma, but she has a clear clinical benefit. So that would be, if you like, a very appropriate patient, or if you like, it would be the ideal patient, where you can expect and then in fact also clearly see the benefit after a short, relatively short period of time. So I think we've run out of time. So
okay, yeah, we'll have some time for discussion because it was very interesting. So thank you for this very interesting and very updated talk on Xolair with all these recent publications. So I will open now the floor for questions. Dr. Deeb.
Dr. Chapin from France, the medication dosage you showed and what we are using said that it's not recommended to use more than 600 milligrams every 2 weeks. What is your feeling about this statement?
My feeling about that is, unfortunately, it's not about feelings in this case. So, I mean, really, it's written on paper. So you have to adopt the maximum dose is these, what you said, every 2 weeks, the 600. And that's it. You cannot go beyond that. And I would definitely not recommend that you go higher than that. It's been studied only, the safety data I can guarantee is within the dosing table. Everything that goes beyond that, we don't have any safety data. So that will be experimental. And I appreciate that in many patients you have the feeling, can we maybe give even more because maybe you have higher IgE. But unfortunately, the answer to that from my side is, at least I cannot recommend it. And I wouldn't recommend it.
Dr. Deeb, yes.
Dr. B, we know that as you explained very well, Xolair in allergic asthma. Let's take an example according to European and international recommendation. But let's take a patient with asthma. Mm-hmm. I am an allergologist, and I have a feeling, even if he has a positive one, let's say positive skin test, and a positive IgE, specific IgE, I have a feeling this patient is not. There is no correlation between the positive skin test and his asthma. I would call it non-allergic asthma despite positive allergy evaluation.
Yeah.
So this is a tricky. Do you put him on Xolair? And this leads me to: do you have a personal experience of
Yes,
Xolair in non-allergic asthma?
This is why I love this interaction. I mean, as I said, this is evidence-based academia, and this is practical medicine. And there are many cases that do not fit into all that. Your point is well taken. From a clinical perspective, I agree. If you only have one positive result and you're not sure whether there's a causal link, it's philosophical. Should I call this allergic asthma or non-allergic asthma? I would say, clearly, as there is an association of atopy and the severity of asthma, if your patient has severe enough asthma to justify treatment with Xolair, and he fits into the prescription label in a way, I would say, even if you're not totally convinced of the causal relationship, I would say give it a try. Because, as I said, in many of the studies, there's a big study in the United States where they did recruit patients, not even according to allergic history, no skin test at all, just severe asthma. And even in this study, where they did a post hoc analysis and they found out that many patients had no allergic background, even in this study, they had a significant reduction in the exacerbation rate. So, what we do with skin testing and total IgE is a guidance, but it doesn't tell the whole story. As I say, there may be patients that 5 years ago we would have considered totally as non-allergic. And we find out, if you look at biopsies, wow, there's massive local IgE production going on, and these patients have dramatic benefit by anti-IgE. If you would have asked me 10 years ago, should I do a study in non-allergic polyposis with anti-IgE, I probably would have laughed at him and said, I don't believe you will see any effect. I mean, this is science, it's evolving. And I appreciate comments like that because, in a way, then you are your N of one trialist. If you think the severity of asthma justifies, I would clearly recommend give it a try. Yes?
If I may just add one...
We have to continue, please. Dr. Zuhair.
Yes, I had the same question. You answered it. Off-label prescription of Xolair in case of negative results. I think you answered it.
Okay, maybe two more questions.
Thank you very much for this second presentation. I was wondering, the graph which you showed when we withdraw Xolair, it was having a dip. So does that mean you're trying to show that, we do not say that the disease will not come back, but it will not come back stinging as before? Or in other words, does it modify a patient in the prospective sort of...
That is a very good question. It's difficult to show in terms of clinical relevance. The first concern was, when we put patients on Xolair, was that the idea was maybe we suppress IgE, we take the drug off, and then we get rebound. So patients go beyond their levels. Now, what is clear now from evidence is the longer you treat, it obviously decreases the basal production of IgE. So if you put patients off treatment after maybe 2 years or 3 or 4 years, it takes a very long time for IgE to come back, and in many patients it does not reach the pre-IgE treatment level. It's lower than that. Whether this is clinically relevant disease modification, I leave it up to you. I cannot associate this clearly with symptoms or whatever. However, it is clear that if you take the drug away, it comes back again and symptoms evolve. And
the last point, we've been hearing a lot of times about the cat, the allergies.
yes.
We did hear once in the ATS some years ago, there was a gentleman who showed us strong data. In fact, it's the other way around. He said it's better to have cats earlier on and not have allergy at all than not to have cats at all. So I'm getting confused. Shall we get the cat out or keep the cat at home?
If you are sensitized, put 4 pediatricians, 1 epidemiologist, and 1 immunologist in a room and let them discuss.
Yes, exactly.
You enter the room, maybe 2 hours later, you will find any of them alive. Because the one says, already you have to put the cat into your cord blood. And the other one would say, yes, it could be helpful in the first week when you're when you're born in hospital, but then put it away for the second week and reintroduce the cat if you're 6 months. I think, frankly, this is all rubbish. I'm sorry. There is basically no concrete information you can get about that. What do you tell your patient? Oh, get a cat now, but remove it later on. If you're allergic to a cat and you have manifest disease, it's not about prophylaxis or whatever, balancing or whatever your immune system. It's about the plain fact that you have severe asthma and you're allergic, and there's clear symptoms when you have contact with the cat. There's only one recommendation: get rid of it on the next street, and hopefully the next car will run it over. That's it.
Okay, if there's no more questions, just a comment about the 6 month. Actually, in Lebanon, we don't have restriction on the 6 month. It's only a perception that physicians had,
Okay.
but for the coverage, it goes beyond 6 months, and I think we have more data that we should continue beyond these 6 months.
Yes.
So thank you very much for your attendance and for your talk. Thank you.